PCOS, the most common hormonal condition in women, and the most misunderstood. Polycystic ovary syndrome affects roughly 1 in 10 women of reproductive age. It is the leading cause of irregular cycles and of difficulty conceiving. And yet studies suggest most women who have it are walking around undiagnosed, often for years. Start with the name because the name is wrong. They are not cysts. What an ultrasound shows are many small follicles, each holding an immature egg, that started to grow and then stalled. In a typical cycle, one follicle becomes dominant and releases its egg. In PCOS, none of them takes the lead, so they sit there and ovulation does not happen. Diagnosis uses 3 criteria, and you need any 2 of them. First, irregular or absent ovulation. Second, excess androgens, shown either by a blood test or by signs such as unwanted hair growth and persistent acne. Third, the appearance of many follicles on ultrasound. 2 of 3 is the rule, which is why you can have PCOS with completely normal-looking ovaries. Underneath, 3 things are usually out of balance. Androgens run high, which drives the hair and skin changes. LH tends to sit high relative to FSH, which is part of why follicles stall. And in most women with PCOS, the body responds poorly to insulin, so the pancreas makes more of it, and high insulin pushes the ovaries to make still more androgens. It becomes a loop. What women actually notice tends to fall into 3 groups: cycles that are long, unpredictable, or that disappear for months. Signs of excess androgens: coarse hair on the face, chest or abdomen, acne that persists past the teenage years, or thinning hair at the scalp, and difficulty conceiving, which for many women is the reason they finally get tested. Here is a correction worth making clearly. Being overweight does not cause PCOS. Plenty of women with PCOS are lean, and the condition has a strong genetic component. What is true is that the relationship runs both ways. Insulin resistance makes weight easier to gain and harder to lose, and extra weight can make the hormonal picture worse. Blaming the patient for the condition gets the biology backwards. Treatment is aimed at what bothers you because there is no single cure. For cycles and androgen symptoms, the combined pill is usually first line. For the metabolic side, improving insulin sensitivity through movement and diet does more than any single food rule, and metformin is often added. And for fertility, letrozole is now first line for inducing ovulation, and it works better than the older clomiphene. 2 long-term points matter. Because ovulation is infrequent, the uterine lining can be exposed to estrogen without the progesterone that normally balances it, which raises the risk of the lining becoming overgrown. Most guidelines suggest making sure you have at least 4 bleeds a year, with medication if needed. And PCOS carries a higher long-term risk of type 2 diabetes, so periodic screening is worth doing rather than skipping. If your cycles are consistently longer than 35 days, if you have fewer than 8 periods a year, or if unwanted hair or persistent acne is bothering you, ask for the assessment. PCOS is common, it is manageable, and most women who have it can still conceive. What it should not be is undiagnosed for a decade.